Stomach and Duodenum, presented by Dr. Gary Marshall, Associate Professor, NYU Medical Center. Please welcome Dr. Gary Marshall.
Good morning. Thank you very much for allowing me to speak this morning. And as she mentioned, the first topic we'll be discussing is pathology of the stomach and duodenum. I have nothing to disclose here. So basically, the modules we'll talk about today will include the basics of anatomy, physiology, ulcers, both gastric and duodenal, post-gastrectomy syndromes, although these are much a thing of the past as we're not doing a whole lot of this operation anymore. We'll discuss lightly as some of these clinical syndromes may arise. Zollinger-Ellison syndrome, Mallory-Weiss syndrome, gastric neoplasias, GIST tumors, and we'll touch on morbid obesity. So for the basics. First question, which of the following statements is true about the basics of the stomach and duodenum? A, the left vagus nerve lies posteriorly on the esophagus. B, the parietal cells are primarily responsible for secreting pepsin. C, the cephalic phase is vagally mediated. D, all of the above. Yeah. All right, great. Everyone kind of got that. We'll go over and touch on all of those. And so for the anatomy, we have the esophagus, the esophagogastric junction, you can see entering into the fundus, both the lesser and greater curve, the antrum lying just below the pylorus, and then entering into the duodenum and the antrum. The blood supply of the stomach, remember, one of the key points is that the blood supply of the stomach is very rich. The stomach can survive on any one of the four major arteries. You can see here there's both the left and a right gastric and the left and right gastroepiploics. There's also branches of the gastroepiploics that make up the short gastric arteries to the spleen that are important. Another thing to remember here and a key in the surgical principles is that the duodenum and the pancreas share the same blood supply. And that's why we can't really mess with, take out one without taking out the other. The reason that the Whipple procedure involves so much reconstruction and removing those is that they're so enmeshed and that the blood supply is essential to both. This also can play into why we have so much trouble with bleeding when we get into gastric ulcers and some of the other persistent problems that may arise. The innervation of the stomach is from the vagus. A little mnemonic to remember is left anterior, right posterior, or LARP, which will help sort of figure out how the rotation. So the left vagus nerve comes down and rotates anteriorly. The right then ends up in a posterior position. Here you can see that some of the anterior nerves and some of the lines of division where you go either for a high truncal vagotomy or a more highly selective vagotomy right there at the EG junction. This helps to preserve some of the branches to both the pylorus and the liver and gallbladder. So for the body and stomach, the acid-secreting cells are the parietal cells, and this is the chief source there. And in addition, the intrinsic factor, which is required for B12 absorption in the terminal ileum, is also made by the parietal cells. This is important when we talk about some of the physiology after a gastrectomy or after some of our other procedures that are gastric limiting. The chief cells are responsible for secreting pepsin. In the antrum, mucus is made, which helps to digest the food and then can be a little bit protective later as we enter the duodenum. And the gastrin-secreting G cells. This is important in the surgical treatment of ulcer disease because retained antrum can leave a source of gastrin, which can lead to recurrent ulcers or a failure of your acid-controlling procedure. There's several phases of acid simulation. The first is the cephalic phase. This is what starts even before the food gets to your mouth. This is vagally mediated with acetylcholine acting on the parietal cells to release acid. The second phase is the gastric phase, which is stimulated by the mere presence of food within the stomach and distension, and then you get more of the gastrin release and the parietal cells secreting. And then finally the intestinal phase, and this is where you get gastrin from the duodenal G cells. Remember, in gastrinomas, which we'll talk on later, much of these cells lay in the duodenum and pancreas. So first, ulcers in general. There's several types of gastric ulcers. The first is type 1. This is the most common. This is up on the body of the stomach, as you can see here in the diagram. It is not antral and is proximal to the incisura. Type 2 ulcers are easy to remember because there's two ulcers. One is similar to a type 1 and the other is duodenal. Type 3 is when you have the prepyloric ulcer. And then type 4 is a general up near the EG junction, very high. This one is less common, but is difficult surgically if you have to get there to try to maintain any amount or volume of stomach and also to have the esophagus preserved. One of the keys here is that type 2 and 3 have to do with secretion of acid. So that's the one where there's two ulcers, where it's duodenal and on the body of the stomach, and then the prepyloric are also acid-mediated. Type 4 tend to be more related to NSAID use or smoking or some of the other causes. The annual incidence of active ulcer disease is shrinking and shrinking. I'm sure for many people trained, these were much more common procedures for ulcers. Now, these days, we don't see a whole lot of surgery on these, especially the larger acid secreting due to the advent of proton pump inhibitors. There's only now about 300,000 new cases per year. There's four basic ways that these can present. The first is abdominal pain. This is usually in the epigastric region. Food and acids relieve the pain. Unfortunately, that's for only a short duration, and then the pain returns. Perforation can also occur, bleeding, and obstruction. So kind of these four are the generalized way, and kind of the whole way a lot of general surgical issues are present was with the pain, perforation, bleeding, and obstruction. Peptic ulcer disease, there are several causes. H. pylori has been identified as one of the largest causative organisms and has really changed therapy and or need for further surgery on ulcerative disease. NSAIDs are still a big player. We still have a lot of people taking these drugs. Acid, smoking, steroids. The diagnosis, endoscopy is the mainstay. It's good. You can get a tissue biopsy. You can get cultures if needed to determine if H. pylori is indeed the causative agent, and you can also localize the ulcers. So H. pylori is associated with 90% of duodenal ulcers and 75% of gastric ulcers. You can get a 50 to 80% recurrence rate if you don't take care of this. And this is why this was such a great discovery, is that nearly all of these ulcerative diseases used to recur. And now we can eliminate a large source of that. The bug itself produces a toxin which causes local tissue injury. In addition, a local mucosal immune response is activated, which causes more and more inflammation to arise. Gastrin levels are increased. One of the big players is histamine and methyltransferase. That is unlikely to be one of your questions on the boards. The boards are largely, having just gone through this, clinical-based scenarios. So as you approach these questions, you're going to see not someone asking you what is the causative chemical of H. pylori disease, but you'll be presented with a clinical scenario talking about someone who has come back in with recurrent ulcers in the duodenum, and more on what you would do to treat that as a clinical surgeon, not as someone taking the in-service exam. Diagnosis of H. pylori, this is important. There's a variety of ELISA tests. These are 90% sensitive and specific. This can be done as basic serology, so for convenience of use, this is probably the best. Carbon-labeled urea breath test. This is also very good. One of the better ways to use this is 4 weeks after you've done something to see if you've indeed eradicated H. pylori. There's a rapid urease assay with endoscopy. You can also, when you're doing endoscopy, obtain cultures. This is only 80% sensitive on the cultures, but it does allow you to determine antibiotic sensitivities in case for some reason you're having trouble treating, although the regimens are all pretty similar for how to treat these with antibiotics. In addition, you can just get tissue and do a GEMSA stain or one of the HENTA stains and look for the actual organisms. So treatment of H. pylori is 14 days of treatment. It requires a proton pump inhibitor and complete acid suppression, along with antibiotics for that. And that can be either clarithromycin and amoxicillin, or in the penicillin allergic, you can switch to Flagyl. Now moving on to just isolated gastric ulcers. Upper endoscopy for bleeding reveals a gastric ulcer with a visible vessel near the pylorus. What is your first level of management? A, total gastrectomy to stop the bleeding. B, endoscopic management of bleeding. C, wedge ulcer and truncal vagotomy. D, antrectomy and truncal vagotomy. E, highly selective vagotomy without biopsy of ulcer. Yes, endoscopic management of bleeding. Again, endoscopy has really taken away a lot of the role for the surgeon here, unless you happen to be also skilled in endoscopy and taking care of a lot of these. So an overview, again, gastric ulcers, NSAIDs, it's often dose dependent. This will be something as you're approaching the exam, there'll be maybe a history of steroid use, a history of a recent injury with lots of sudden NSAID use after, say, a fracture or something. They may bring the question to you in that manner. There's also acid. Zollinger-Ellison syndrome can occur. This is another popular test question, although it's not that common a disease because of the association with MEN1 and the ability to tag in multiple things there in terms of testing. Zollinger-Ellison, and we'll discuss this more at length, it causes ulcers in abnormal places and a high volume of ulcers. And then cancers can also do this. Remember, if you see a large ulcer, you should biopsy it. So with bleeding, the mortality is about 10%. Therapeutic endoscopy is the mainstay of treatment. The presence of a visible vessel or pulsatile bleeding is one of the stigmata of rebleeding, and it can occur in 50 to 80% of patients when they have these signs present. So for surgical options, you can do distal gastric resection with inclusion of the ulcer. Can do a gastrotomy and just oversew in very high-risk patients where you don't have time to be doing reconstruction and a VNA and a Billroth and all those things. Just get in. Usually these patients, if they're having bleeding, are going to be sicker than most and really in a damage control style. You really don't have a lot of time to do an operation you haven't done in quite some time in the OR, and you really just need to stop the bleeding acutely. And so that is an option. A vagotomy and drainage procedure has the least recurrence. Again, not something that's always in most people's armamentarium, and also something that the way most patients present now, they're usually a failure of PPIs or something else is going on. Maybe it's they're sick and in the ICU. They aren't going to tolerate a whole lot of operation. In addition, at least in my own practice, the more and more time I see these is in older patients and frail patients, both with perforation and bleeding, that are less likely to take a whole lot of operation. So the switch of treatment has been to a lot of damage control. Get in, get the job done, and get out while you're still fighting, because you can always start the PPI afterwards and get them on that. Perforation is the least common sequela. This can be managed non-surgically in a patient with a CT that shows a sealed leak. You have to really be sure that that's what the pathology was. If you're going to try to manage someone who's at free air, suspected perforation, who's now controlled, and the methodologies, if your patient's stable, not septic, not sick, you can get a upper GI or CT with oral contrast, and if it shows that it's completely sealed off, you can go ahead and try to manage non-operatively with just antibiotics alone. This can be successful. But again, you have to be pretty sure of what you're dealing with, and a lot of times when you present them with that patient with free air, you don't exactly know the source. There's a suggestion and something to let you know where you think the source is, but you got to be pretty sure here. You can also do a gastric resection locally. You might consider vagotomy and drainage for type 2 and 3, and again, these are the acid-related ulcers. Then again, with the unstable patients, local excision, biopsy, and an omental patch, and get out of Dodge. Some of the surgical options, again, were the Billroth 1, Billroth 2, and the Roux-en-Y. These had all sorts of complications, and we'll talk about some post-gastrectomy syndrome as well as the difficult duodenal stump. When you're unable to close, you need to do a whole lot of things to manage these duodenal leaks, as they can be devastating if they're missed or occur later. So in the surgical options for type 1 ulcers, again, conservative treatment. Most of these are H. pylori related. For refractory, you can do a vagotomy and antrectomy with Billroth 1. Remember, a Billroth 1 is where the stomach remnant is re-anastomosed directly to the duodenum. Billroth 2 is where the remnant stomach is anastomosed to a loop of jejunum. Type 2 and 3 are acid related, so you need to do a complete antrectomy. Things to avoid here are retained antrum. So if you see a stem of someone who's had an ulcerative procedure, they come back again, they have high acid and secretion. One of the choices you may want to rule out is the presence of retained antrum, because you're still getting a very high gastrin signal now to produce more acid. Type 4, at the G junction, there were several described, the Pauchet and the Sendez procedures, and these had to do with excising very high up on the lesser curve and then angling your incision down toward the mid and body of the stomach so you have enough remnant to reconnect. Type 5, stop the NSAIDs, of course, is the first, and then a PPI. EGD is your second option for control of the bleeding, help to localize this. This is useful when it's a single area bleeding or several small but not a lot. Sometimes it's the whole stomach that's bleeding, or someone who's very sick, and so that can become a little bit more difficult. If you have a failure of EGD, coil embolization of the gastric vessels is also useful. They can now identify these. Because the stomach is so richly vascularized, they may have to do more vessels than just the one that shows the bleeding to remove that pressure head of the bleeding. As a last option, surgery, and again, options here include a gastrotomy with oversewing of the bleeding sites, a total gastrectomy for complete failure to control, and then devascularization is not usually used. Usually just tying off 3 of the 4 vessels to the stomach isn't necessary, because you can do that with coil embolization without having to get into the OR. The stomach can survive on one vessel, and when you think of all the gastric pull-ups to replace the esophagus, they're usually living on one vessel, and they do just fine and heal the anastomosis. So there's a whole lot of blood here. Stress gastritis is something we, again, don't see quite as much of as we used to now that we have so many options for acid suppression while in the ICU scenario. Usually this is coagulopathy, patients on mechanical ventilation for more than a couple of days, and then low platelet count, or the INR gets up. Early prophylaxis is the hallmark to preventing this. The best way to deal with this is to prevent it in the first place. Here's a nice little algorithm that patients presented to you. First endoscopy, heater probe or coagulation injection, then move on to angiography with embolization or a local vasopressin control. If it's localized then and you end up in the OR, you can do the gastrotomy and oversew, or just do a partial gastrectomy, just incorporating the bleeding area. This can usually be easily accomplished with staplers or any sort of form if it's localized. If it's diffuse, you then get into a subtotal or a total gastrectomy, or a gastric devascularization and truncal vagotomy to again cut down on some of the acid secretion. Moving on into the duodenal ulcers. Factors on upper endoscopy for a bleeding duodenal ulcer indicative of failure of non-operative management include A, active bleeding, B, a visible vessel, C, an adherent clot, D, all of the above. That's right, all of the above. Active bleeding, visible vessel, and that clot that's just sitting there that is recently formed. Usually they won't, some of the endoscopists will try to dislodge this just to go ahead and see the bleeding, but these are all concerning findings. So bleeding is the most common complication here and the reason for death. Resuscitation, blood, reversal of anticoagulation, NG tube decompression, and endoscopy are all parts of therapy here. You really just got to get the bleeding to stop. Correcting the coagulopathy and Any low platelet count is essential, as you're just not going to stop bleeding, and all of the heater probes and the cautery and injections rely on the blood's ability to clot, since they can't tie off a vessel. They don't have that option here. The clips may help with some of that. There are some factors that predict failure of non-operative therapy. This can be transfusions exceeding 4 to 6 units in a 24-hour period, active bleeding, again, visible vessel, an adherent clot, or an ulcer that's greater than 2 centimeters in size. Surgery for bleeding duodenal ulcer, usually an incision is carried down longitudinally across the pylorus. You can then enter the stomach. These diagrams always show that as a tiny little incision. In practice, usually, I'm sure you've seen when there's that much bleeding, you need a little bit more workspace than a 2-centimeter incision across the pylorus. But there's 3 points that have to be tied off to get the entire supply from the gastroduodenal and some of the others, and that's shown in this diagram, the 3 vessels that need to be got. It ends up making a T configuration with the base of the T toward the stomach and the top above. And then the stomach is closed transversely to prevent any stricture. This is sort of like a stricturoplasty, cut one way and close the other to make sure that you don't have any issues there with stricture and gastric outlet obstruction later on. So again, other options, pyloroplasty and truncovagotomy. Remember, when you do that vagotomy, you need some sort of drainage procedure to allow the stomach to relax. Truncovagotomy and antrectomy. This is basically the 35% distal gastrectomy. This has your lowest recurrence rate by far, but it's the highest in terms of morbidity and mortality. And the role of it as a gold standard has come into question as, again, by the time you've gotten into the OR with someone with a bleeding DU, they've been transfused 6 units, they've been through a lot of failed endoscopy procedures, they're not quite ready to tolerate a large operation. Recent studies suggest angioembolization is actually beginning to work. These guys in IR are getting better and better at getting these vessels, especially the small ones. So for perforation, omental patch and acid suppression is still, the Graham patch is still the mainstay of treatment here. If there's more that needs to be done, you can perform the proximal vagotomy in a stable patient or with failed medical therapy. Again, most surgery remain for those people that have either completely failed with proton pump inhibitors or for some reason will not take them, and you kind of have they might present in the stem somebody who's homeless and is unlikely to follow up and probably will never get their PPI prescription filled again. These are cases where you might consider doing more of a surgical option and how that will be presented to you. But for the most part, 90%, 95% proton pump inhibitors are the way to go in terms of secreting this. If they're trying to lead you to do more, it might be that presentation of someone who you just don't think is going to be reliable or who has failed. For obstruction, a malignancy must be ruled out. You want to make sure this isn't a tumor and not just the obstruction to the ulcerative disease. Endoscopic dilatation is now the first line of treatment here. This can be done multiple times. Then you move on to, again, all of the other usual procedures. Highly selective vagotomy with a gastro-J, resection with or without the entrectomy. And then the duodenal stump, some people advocate for decompressing these with a retrograde jejunal tube to get back into the duodenum. Again, you want to drain widely. Usually this duodenal stump, because the ulcer disease is not the best tissue, and so you're working with, you're sort of behind the 8 ball in terms of failure of your operative procedure after going through these procedures. So drainage and safety are something you'll want to get out here. It's not recommended to make extra holes in the duodenum, but rather to feed back a retrograde J tube into the area in healthy tissue and away from the site of the surgical. A lot of times when those are done, they'll use a double J tube technique, one retrograde to drain the duodenum and one antegrade for feeding so that you can get some nutrition started early in the post-operative period. So laparoscopy can be done with duodenal and gastric ulcers. You can do a truncovagotomy, proximal gastric vagotomy. All of these have been done laparoscopically. Pyloroplasty, entrectomy. Omental patch can be done. Usually the omentum is already sealed off the thing, so it's just a matter of unpeeling the omentum that's fixed it and adding a couple sutures to it laparoscopically. This is probably the easiest of all these operations to do. There's still a 20% conversion rate. Sometimes these ulcers you just can't get to it due to the inflammation, or it's hidden by the liver or too adjacent to another structure where you're really not comfortable working with it, or just can't get at it to do that. Again, that's all depending on skill set. If you're someone who's in the foregut all the time, you may have a better shot of first pass with the laparoscope. There's no hesitance, no reason ever not to convert, especially the laparoscope can really help you on those questions where the free air, you don't know the source. You think it's a gastric ulcer, but maybe it's diverticulitis or another thing. You put the scope in, figure out exactly where it is, and then make a targeted incision right at the area of pathology so that you don't end up with someone sort of split from stem to stern. You cannot rule out malignancy here. One of the problems is you lose that tactile sensation. You cannot feel to see if there's a mass there. It's a little bit harder to cut away and biopsy tissues. So that direct contact with the tissue is missing with the laparoscope. So some post-gastrectomy syndromes, again, we don't do a whole lot of gastrectomies, but these do occasionally show up. First question. Following gastrectomy, a 53-year-old otherwise healthy male complains of postprandial pain relieved by explosive bilious emesis. This is most likely secondary to A, dumping syndrome, B, bile alkaline reflux gastritis, C, gastric stasis, and D, afferent limb syndrome. All right, that is correct, afferent limb syndrome, and this is a complication related to Billroth 2 reconstruction only. We'll talk a little bit more about each of these. So dumping syndrome, this is usually an early phenomenon where the hyperosmolar chyme gets into the intestinal tract and there's rapid fluid shifts. These are usually protected in the stomach but may occur in the intestines. Later on, you get a hyperglycemic phase, rapid secretion of insulin in a following hypoglycemic phase. And this is where most of the symptoms arise, the palpitations, the sweating, and all those things that go with hypoglycemia. This can be dealt with dietary and medical management. For the most part, separating food and liquids and eating small sort of dry meals can help. Octreotide may be helpful. And then you may need to convert whichever the surgery you started the first time to a Roux-en-Y procedure. Afferent limb syndrome, as was mentioned in the question, is a Billroth 2 phenomena with duodenal limb obstruction. Basically, that limb draining the duodenum and pancreas gets obstructed. It gets fuller and fuller and fuller, and finally you have that explosive emesis that relieves the pain until it occurs the next time. In this, you can convert a Billroth 2 into a Roux-en-Y procedure, or there's an older procedure, you may remember the Braun enterostomy, where basically the efferent limbs are just a new anastomosis is created between those two so that you avoid that obstruction phase at the gastric anastomosis. This is not good to happen in the immediate postoperative period. If that duodenum stretches before your staple line is healed, you can have a blowout of your suture line, which can be catastrophic. The acute syndrome may require a tube duodenostomy. Again, not the best place to put a tube, and I think this is still what the textbooks say, but putting extra holes in the duodenum when the duodenum's not doing well is often ill-advised. Try to get away with drains from remote, and we have long enough tubes to get there in another way. Post-vagotomy diarrhea. This is really only clinically significant in about 5% of patients, very rarely debilitating. Increased fiber, small dry meals, all pretty simple management. One of the things to consider here is bacterial overgrowth, especially if there's a roux limb, like roux limb stasis, or an afferent limb. Because there's no acid, you may see these syndromes. Inflammatory bowel disease, malabsorption, and dumping, these are other considerations. After all other causes have been excluded, there is one surgical procedure. I don't know that I've ever seen it done, but you can take 100 centimeters from the ligament trites, taking a 10-centimeter segment of the small intestine, reversing it, and an anastomosing to get a reverse peristalsis may slow down some of the forward feeding. Again, that's probably much more of historical significance than anything that's going to show up come December. Bile alkaline reflux gastritis, again, this is removal of the pylorus, so basically the bile is getting back into the stomach. This causes nausea, epigastric pain, and burning. Bilious vomiting does not relieve the pain here, and that's probably the key differentiation, and that's because there's just this constant efflux of duodenal contents and bile into the stomach. If it is hypergastrinemia, must exclude Zollinger-Ellison syndrome. And then most common post-gastrectomy syndrome requiring revision is this, and usually what you do is take that Billroth 1 or Billroth 2 and convert to a Roux-en-Y procedure so you can make a much longer limb, and the chances if you have a 50-centimeter limb of that reflux occurring are pretty low. Gastric stasis and Roux stasis, again, difficulty in any gastric emptying. Upper endoscopy would show a very dilated stomach remnant. You would see delayed emptying on an upper GI study. Early phase, NG tube and Reglan or erythromycin. Surgery is very rarely helpful. You can see here some options. You can convert to near total gastrectomy. You can re-Roux if that's one of the problems. Again, you're kind of replacing what has been a problem with another Roux limb, so that's kind of this is a little bit distressing as it's a little hard to manage surgically. Finally, recurrent ulceration. Again, if you've done a lesser procedure and for some reason you failed, you have to assess for did you eliminate H. pylori, or is that still persistent? Can you get there, or do you have retained stomach? So all of these you can see here have a varying rates of recurrence. Usually the more surgery you do, that bigotomy, entrectomy, Billroth is going to have a much less failure rate, but more morbidity, mortality in the short term. So again, retained antrum, incomplete vagotomy. Remember the criminal nerve of Grassi, which is a very high branch off of the vagus. You need to get up and get your trunks about 4 centimeters off the stomach because there are some high branches off of the left vagus that come and supply the upper part of the stomach that are pretty easy to miss unless you get high enough up there. Other options, again, for thoracic vagotomy, if you really need to get up that high, people can put in a scope now and get your vagus higher up. You can convert from highly selected to total VNA. If there's retained antrum, unfortunately, you need to consider an antral resection. Remnant carcinoma, again, pretty rarely seen. This is usually a Billroth procedure. You get achlorhydria or hypochlorhydria. It may lead to some metaplasia or dysplasia, which is later carcinoma. I don't know that I've ever seen this or heard of a patient with this. It's a late consequence. Billroth 2 has the highest incidence. Endoscopy and biopsy are the way to diagnose and see this. The treatment would be residual gastrectomy and esophagojejunostomy. There are some nutritional and metabolic considerations here. Again, vitamin B12 deficiency due to less parietal cell mass is one to consider. And again, if that were coming as a question, it might show you someone who's had one of these procedures, or it could have been a bariatric who now has anemia, and they'll say those things, and then you might get along to coming up with the B12 deficiency. It will not be usually list the 5 nutritional consequences of a gastrectomy, but rather present you someone in a clinical scenario so that you can put 2 and 2 together and see that that anemic patient is now probably B12 deficient. Calcium deficiencies due to the duodenal bypass can occur. Gastroparesis or intestinal stasis leads to bacterial overgrowth. Again, a lot of these go with the bariatric surgery as well. This interferes with the absorption of fat-soluble vitamins. Vitamin D is needed, so you must supplement vitamin D and calcium to prevent bone loss. Zollinger-Ellison syndrome, we'll talk about for a few slides here. Which of the following tests are useful in diagnosing Zollinger-Ellison syndrome? A, gastrin level. B, gastric aspirate pH. C, secretin provocation test. Or D, all of the above. Excellent. Just about everyone got that. We'll go into more detail on all of these various tests. I have another question. The goal of surgical treatment for Zollinger-Ellison syndrome is A, total gastrectomy, B, lesser acid reducing procedures, C, tumor removal, or D, none of the above. Tumor removal is, again, the treatment here. Remember, these are pancreatic neuroendocrine tumors. They can be anywhere. We'll talk about the gastronoma triangle, but they can be the stomach, the duodenum, the pancreas. Simply getting rid of the entire stomach is not your first choice. In overview, this is peptic ulcer disease caused by gastrin-secreting duodenal or pancreatic tumor. The gastrin has a trophic effect, and this can lead to some extra folds that you might see in a characteristic endoscopic appearance. But the parietal cell mass is increased, and the histamine-secreting cells are also increased. Again, histamine is another of the stimulations, as well as acetylcholine and gastrin, for acid stimulation. It's a rare cause of peptic ulcer disease, but it is present in about 2% of recurrent cases. So again, if you're presented with recurrence, this is another of those you want to check a gastrin level. 80% of these are sporadic. 20% occur as part of multiple endocrine neoplasia type 1. With patients with ZE, 90% of them have peptic ulcer disease. The ulcers are most common in the proximal duodenum, but they can also be in very unusual locations in the distal duodenum and into the jejunum. And so if you're presented with a case and you see on endoscopy the patient has ulcers in the proximal D2 extending in the jejunum, check a gastrin level, consider Zollinger-Ellison, consider the other parts of the workup for multiple endocrine neoplasia. 10% will present with perforation. About 1 in 10 will have inflammation or stricture at the esophagus. 70% have a secretory diarrhea associated. The cardinal signs to work up here, and these are something to remember. Ulcers located in distal duodenum and jejunum, multiple or recurrent ulcers, ulcers associated with diarrhea and weight loss, prominent gastric folds, and then ZE in any patient who has primary hyperparathyroidism and kidney stones should probably be worked up. So that's a good question to ask, is have they had nephrolithiasis? Any family history of pituitary and parathyroid tumors should probably prompt workup as well. So for the workup, normally your fasting gastrin level is less than 110. If you have a level greater than 1,000, that's pretty much pathognomonic for it, and it's near diagnostic. However, 60% of ZES patients will have a gastrin that's below 500. The gastrin secretion test is if you take a gastric aspirate, the pH is under 2, and there's still very elevated gastrin, that's pretty much shows you the feedback loop is going and you're just constitutionally making gastrin. These are all best done off proton pump inhibitors for 72 hours, so usually a very unhappy patient. But you want to hold those for 72 hours to get a real idea of where you stand. If any questions linger, you can do the secret and provocation test. This gives you get a fasting gastrin level, give us a creatine ID, and then check your gastrin at 0, 2, 5, 10, and 20 minutes. Increase greater than 200 in the gastrin level is sensitive and specific for ZES. Here's tumor localization. You can see that all of the different locations. Remember, the gastrinoma triangle extends from the confluence of the cystic duct and CBD over to the junction between the body and neck of the pancreas down to the junction of D2 and D3. You want to look everywhere in all of those areas. There's a million tests that you can do to do this now. There's a good 5 or 6 different ways that we're looking. Somatostatin receptor scintigraphy now is the preferred test of choice. This will show you tumors just about everywhere. It's the least invasive and the most sensitive, as you can see here by the numbers. Ultrasound is possible. Intraoperative ultrasound can be very useful in finding those smaller tumors within the duodenum or the pancreas if you're having to excise. Angiography at times can be used. Secretin angio is possible. It's about 82%, but again, much harder to do than just the somatostatin receptor scintigraphy. So if you're presented and you want to rule out MEN1, there might be a battery of tests that they suggest to do that. So for the pituitary, just check a prolactin level. For parathyroid adenoma, calcium level and parathyroid hormone level. For the pancreas, these are pretty simple. They're all named for what they secrete. Gastrinoma, check the gastrin. Insulinoma, glucagonoma, look for your glucose level there. VIP-oma is pancreatic polypeptide level. And then finally, somatostatin level. Zoledronelsin occurs in about 25% of those patients that have MEN type 1. Medical treatment is PPIs. This may need very high dose therapy at the start, but can later sometimes be blocked down. H2 blockers are not as effective. They need periodic gastric surveillance endoscopy. Octreotide can be used, but this is a second line of therapy. Surgical treatment. Any patient with sporadic form should undergo surgery. They have a much higher malignant potential. They have about a 60% resection for cure rate. Part of the intraoperative looking, you want to do a full Coker maneuver, mobilize the pancreas, intraoperative ultrasound. You can make a duodenotomy, look around on the inside, or transilluminate the duodenum as well to find all of these tumors. In the head of the pancreas, simple enucleation is adequate, both there and in the tail of the pancreas. Duodenectomy palpation, if you see some gastrinomas, those can be excised there. Whipple's very controversial in this. Again, these tumors are recurrent. They occur just about everyone. So this is a big operation to undertake for what is unlikely to be a permanent cure. The lymph nodes around the duodenum and pancreas should be explored, palpated, and then the liver as well for isolated tumors. With MEN1, they both metastasize to the liver at the same rate. Chemoradiotherapy are not useful here. Octreotide, interferon alpha, again, ineffective. Liver resection is appropriate if there's no other metastatic disease and you can get rid of 90% of the tumor burden. If it's scattered throughout the liver, that's not going to be that helpful. But if you have one large tumor or the burden confined to allow you with an adequate liver remnant, then that partial hepatectomy would be indicated. There's no consensus really on the management of surgery in MEN1. If you have hyperparathyroidism, undergo parathyroidectomy. Medical management is going to be the mainstay. Resection for cure is not possible, where there's a 95% biochemical relapse 3 to 5 years. And that's why some of this surgery is really buying you time or getting to reduce that tumor mass. Tumors greater than 2 to 2.5 centimeters, it is recommended that they undergo surgery. The rest of this is kind of still up for debate. So the outcomes, you have disease-free survivals improved at 15 years, and there's a possibility of cure. In sporadic, a surgical cure is achieved in 60% postoperatively, but this falls to 40% at 5 years and 34% at 10 years. Cure would be measured by normal fasting gastrin, negative secretin stimulation test, or no tumors on imaging. Mallory-Weiss syndrome. This is forceful vomiting, retching, or coughing, or straining that results in disruption in the mucosa high up in the stomach. About 15% of acute upper GI hemorrhage is due to this. 90% of this is self-limited. There is some mortality, but that's usually people with cirrhosis, varices, something else going on. Endoscopy is the mainstay of treatment here. If surgery is required, just anterior gastrotomy with oversewing of the bleeding vessel. This one, again, is usually a very isolated phenomenon. One location, one stitch, and be done. Finally, getting to gastric neoplasia. A 65-year-old male with a non-healing gastric ulcer at the cardia. A biopsy reveals adenocarcinoma. What is true of the management? A, no surgery since this carries a poor prognosis. B, CT scan without metastasis, wedge resection of ulcer. C, CT scan without metastasis, total gastrectomy. Or D, CT scan with mets, total gastrectomy. That's correct. If there's no metastatic disease, the treatment needs to be total gastrectomy. We'll talk about that. Remember, these tumors may appear to be smaller, but can have up to 8 centimeters of spread throughout the stomach. So 90% are gastric adenocarcinomas. There's either intestinal or well differentiated or diffuse and poorly differentiated types. On physical exam, some of the old things you might see here are Sister Mary Joseph's periumbilical nodes, the Bloomer shelf, which is drop metastasis felt on digital rectal exam, and then Virchow's left supraclavicular lymph node. Again, we find a whole lot of these a long time before they end up with these nodes at this point in time. There's a question of resection versus subtotal gastrectomy. For tumors in the distal 50% of the stomach, some maintain that you can do a partial gastrectomy. Anywhere else, a total gastrectomy is the answer, and that's probably the safest answer, although some of the people in oncologic circles debate this and go back and forth. If you've got a large gastric tumor, take out the whole stomach. It's probably your safe answer. Lymph node dissections, this is sort of controversial. D0 is just a palliative, just to debulk. D1, perigastric, and D2 extends to the celiac. Usually in the U.S., people do a D1. There's some Japanese and Asian literature where they see a whole lot more that suggests that a D2 offers some benefit that has not been replicated here. You need 6 centimeter margins because these spread in the submucosa. Remember the term linitis plastica, and why the stomach gets that whole appearance is because of the submucosal spread of this tumor. 42% incidence of recurrence after resection, 80% recur by 2 years. Medium time from recurrence to death is about 6 months. Neoadjuvant postoperative chemo, school's out. There's some thought that 5-FU and leucoborin external beam may help somewhat, but these are not of a whole lot of benefit. Gastrointestinal stromal tumors, this is one that is probably something to learn, pretty simple. 37-year-old female with submucosal lesion of the stomach, 1.5 centimeters in size, is found to be a GIST tumor. What's just true of her management? A, total gastrectomy. B, total gastrectomy with extended lymphadenectomy. C, margin negative resection en bloc. D, radiation therapy. That's correct. Margin negative resection en bloc. Pretty much everyone got that. GIST tumors they come from the interstitial cells of Cajal, which are the gastric pacemaker cells. C-KIT positive, and C-KIT may be something that you see, although these are pretty rare. Platelet-derived growth factor is also there. These can occur in the stomach, the small intestine, large bowel, pretty much anywhere in the GI tract, including mesentery and omentum. Upper endoscopy or CT will usually show you these tumors. The behavior is by size and mitotic rate. If it's under 2 centimeters and under 5 mitoses per field, high-power field is benign. Greater than 10 centimeters, greater than 5 mitoses is considered malignant. These cause bleeding, obstruction, or can be incidental. Surgical resection is the mainstay of treatment. Recurrence rate is 20 to 50%. Again, these are pretty benign acting tumors. They're not known to metastasize. Where they usually cause trouble is because of their bulk or their mass and because they're space-occupying lesions, so obstruction and those type of phenomena. It's recommended that you get a CT scan every 6 months for 2 years. Now we have imatinib or Gleevec. This is a tyrosine kinase inhibitors. This is excellent for treatment with metastatic or unresectable disease and slowing tumor growth. Although not well studied yet, it may have a role in adjuvant therapy or neoadjuvant, getting that tumor to shrink down to a size that's resectable, or in treating post-op. Lastly, for the stomach, we'll talk about morbid obesity briefly. So obesity by definition is determined by height and weight. The BMI is how this is determined, how you decide who gets an operation. And this is just kilograms per meter squared. Some others define it as 100 pounds overweight. There's all things. BMI, though, is the standard by which most of the definitions occur. And again, where you get into deciding who gets offered what operation. 64% of Americans are overweight, 33% are obese. I feel like this slide should have a ticker that keeps going up, sort of like the national debt clock, because it changes every time, and I'll show you a little bit of what we've seen. So first, by definition, the degrees of obesity, a normal BMI is 18.5 to 24.9. Overweight, 25 to 29.9. This is really where you want to start intervening with people, talking about diet, talking about exercise, and all those things. Obese is 30 to 34.9. And then clinically severe obesity can be 35 to 39, severely obese, and then mega obese, which is now BMI greater than 40. There's a lot of these around, unfortunately. When they started looking at this is from the Behavioral Risk Factor Surveillance System, and they looked in 1985, and this shows the percentage of obesity by state. And you can see here that we have some states where it's less than 10, and others are 10 to 14. We move on, and then you see in 1995, now every state has been touched by the epidemic, and you see we've added a new category of 15 to 19% here in the dark blue. Move ahead to 2005. We've had to add categories of 20 to 24, 25 to 29, and greater than 30% by state in just another 10 years. You can see a few states were spared here at that point. This is where we're standing about in 2009. Now you can see that there's one state with less than, and the District of Columbia with less than 20%. Nearly everyone is in the 20 to 30% range, and now there's quite a few states over 30. This continues. There's a lot of causes to morbid obesity, genetic predispositions. There's some physiology of leptin and ghrelin. It's the satiety mechanism. Those are some of the things that we're targeting medically. Unfortunately, a whole lot of things we cannot fix medically. Behavioral, family tradition, gender. Women tend to be more affected than men. Socioeconomic status plays a big role. It's very expensive to eat healthy food in this day and age, and so a lot of the fast food and the poor nutrition is targeted to being affordable. Psychosocial methods, and then a whole lot of societal mechanisms. Nobody plays outside as a kid. They play video games. We all sit at desks and, use transit instead of walking. So there's a lot of things that have contributed. Medical complications, pulmonary disease, COPD, exacerbations, NASH or fatty liver. There can be gallbladder disease, gynecologic abnormalities, joints, especially the knees tend to go. Some cancers are related. And then diabetes, dyslipidemia, hypertension, all of the risk factors for other morbidity, strokes. And then some idiopathic intracranial hypertension. So BMI greater than 40, you can see diabetes 5 times normal, hypertension 5 times normal, dyslipidemia 2 times normal, and metabolic syndrome is double. Reduced fertility, joint pain, sleep apnea, cancers, all of these increase. So in qualifying for surgery, and these keep getting laxer and laxer as people realize the benefits. But a BMI greater than 40 was the textbook, you just got it off the bat. Greater than 35 with any comorbid conditions. Diabetes, hypertension, sleep apnea. You should have documented attempts at weight loss. These are life-changing operations. You have to change just about everything about the way you eat, your social situation, what you can and can't do. So this needs to be a committed individual who can follow the directions and do this. And usually a mental health professional and dietitian should clear these patients. That is something just as part of that evaluation, always consider the mental health side of things and the psychological clearance as well. 3 main operations, the Roux-en-Y gastric bypass shown here on the left, where a rulum is brought up to a very small, maybe 30 cc stomach remnant. The band, which is probably the least effective but the easiest and safest operation. And then the sleeve, which is a gastric restrictive procedure as well. 26-year-old female, status post laparoscopic adjustable gastric band, was placed 1 year ago with dysphagia. What's the first test? CT scan, AP radiograph of the chest and abdomen, upper GI series, or MRI? We missed that. You don't need the upper GI. We'll talk about this. This is usually a slipped gastric band. A simple chest x-ray will show you that that band is now above the diaphragm. So the gastric bypass, this is probably the most effective. About 70% of estimated weight loss on average, 70 to 80 pounds by 2 years if you're 100 pounds overweight, and 150, usually 100 to 110. There are metabolic changes, and these are probably why these tend to work more so than just the restrictive. You decrease ghrelin, which decreases hunger. So again, ghrelin, when that increases, you have an increase in your hunger mechanism, and then some of your satiety are increased by elevations in PYY and GLP-1. As you've all seen, these can be complications. When it goes bad, it goes south really quick. These patients can turn leaks, strictures, dumping syndromes. Overall mortality is about 0.5%. Again, this has all come down with the vast experience and the better technology for doing these. The cardinal sign to cause you to evaluate for a leak is tachycardia. So if you have a patient that's sitting there and suddenly has had their gastric bypass and the next day they're very tachycardic, check for a leak. So that's one of the form-out things that we teach the trainees, and one of the most important things to watch is that's often the first sign. It can be confusing because a lot of these patients at baseline are tachycardic because of the morbid obesity. So you have to watch for it, but it's crucial, and have in that post-op period a low index of suspicion for assessing to see if there's a leak. Metabolic complications, again, iron deficiency, anemia, as we talked about, thiamine due to postprandial vomiting, B12 deficiency, calcium and osteoporosis. All these patients have to go on multivitamins, calcium supplementation, and all these other things, and need to be monitored for this, especially during the phases of rapid weight loss. And then protein deficiencies, you may actually get to the point of needing to supplement with some of the beverages like Ensure or something that has a higher protein content. Lap gastric band, only about 40% of the excess weight loss on average. These are adjustable, so the degree of restriction can be changed. These actually increase ghrelin, which increases hunger. So that may be part of the reason that this doesn't do as well as one would expect. Lap band has the same complications. Again, slip band will cause dysphagia. Chest x-ray will show you that this has ended up in the chest. There can be failure to lose weight. Usually the patients don't follow up. If they don't follow up for all the post-operative adjustments and the refilling of the balloon and the subsequent constriction, the operation will fail. Finally, laparoscopic sleeve gastrectomy. This is about 60% of the weight loss after 2 years. It is a restrictive procedure. It also has the same hormonal effects, so decreases ghrelin, decreases hunger, and increases PYY and GLP-1. If there's a problem with this, it can later be converted to a Roux-en-Y duodenal switch for greater weight loss. This is slightly lesser procedure, a little bit safer, a little bit easier to accomplish because really just it's stapling off that portion of the stomach after you put in a bougie. So it's a little safer, a little easier to do. And someone who's coming in with a BMI of maybe 45, or you're seeing one of these mega obese, you may not be able to get that Roux-en-Y right off the bat, but if you can convert, you start here, you can get some of that weight loss and then get somebody teed up for more operation if they need it down the road once you've gotten them a little safer to get through that. Again, the lap sleeve complications are about the same: infection, bleeding, persistent nausea, and then some failure to lose weight. There was duodenal switch and biliopancreatic diversion. These are really not done anymore. This was basically creating a very long roux limb system where there was only about 100 centimeters of common channel between the food and the enzymes. The nutritional consequences here and the extreme malnutrition it made this operation really not one that anyone's doing anymore. Comorbidity resolution, just about everything gets better. The migraines go away, the blood pressure improves, the lipids improve, the joint pain, everything. So almost all those medical problems can resolve with the weight loss. It's also proving to be a cure for diabetes. Some of these patients will come in on insulin and go home without it. and it's that big a quick, and it's unclear which hormones or what's related to this, that the diabetes and the hyperglycemia turns around so quickly. But even the band can have 50% resolution in diabetes. So this is really probably one of the best things we get out of these operations, and the long-term sequelae of diabetes are eliminated. Just looking at weight loss achieved, the control group on the top, banding and the vertical banded gastroplasty have lesser weight loss, but it is good, and then the gastric bypass has the most, and it's long stayed. This is a nice longitudinal study. At 16 years, those that in the control group had significantly higher cumulative mortality, and it just splayed throughout life. So this has benefits for the life of the patient. Why do people fail at this? It's usually just behavioral. Grazing between meals, these patients need to stick to not snacking. Liquids can be the worst. Drinking carbonated soda and getting a lot of sugar in through fruit juices or colas or Slurpees or whatever it is you like. This is how these operations are cheated. That 30 cc reservoir is just fine for drinking sugary beverages, so it really doesn't restrict. Evening meals should be earlier in the evening, and that's what we have on stomach. Sir. It's usually removed. I don't do the bariatric, but he asked what happens to the rest of the stomach when you've done that. Usually you've cut it off from a lot of its blood supply, so in that case it's removed. In the Roux-en-Y, you leave that full remnant because you've just kind of created the pouch. Any other questions? Sir. Some patients, if they will come and for reversal, and it's usually those malabsorptive, that's sort of like the duodenal switch that I was discussing. It was one of those extreme bypass procedures where that is a reason for reversing those. At this point, because they've not been done in quite a while, I don't think those are coming up near as often for reversal. Usually the metabolic consequences of that are they don't take a lifetime to materialize. If it's too short, within a year or two, you're going to know that you've achieved a pretty high degree of malnutrition. Yes, sir. You want to know how do you collect an incomplete vagotomy? You would still suspect that there's a higher degree of acid suppression, that you still have quite a bit of acid being secreted despite doing your vagotomy. So again, you can look at your gastric pH. To see if it's still 2 or less than 2, you probably haven't done your job, completely gotten it. All right, thank you.